Finish up day two. I just didn't get a chance during the day to have a chat with you. So I've finished up things and I'm walking home now. Was a good day. Pretty hectic day again. I did struggle in a couple of things, but obviously getting hang of things. One was IV cannulation. Had a really difficult case where I had to do a cannulation and was struggling, and the consultant came in and sort of showed me his eyes. But other than that, pretty negative at the moment. So I'll have a chat with you tomorrow, tell you what cases I saw and how things worked out. I'm back again, and this is going to be a continuation of my vlogs for the first few days of a job as a medical officer in Australia, particularly as an IMG. So I'm going to share my experience. Remember, I made a first video on my first day and told you how I felt on the first day. I just have been really busy over the day 2, 3, and 4. So I'm going to combine day 2, 3, and 4 over here and give you a bit of a summary in what happened in the next 3 days. And then I'm going to do a wrap-up video for the first week and tell you what I felt in my experiences in the first week. So just continuing from where I left, generally as an IMG, you may not get a rotation which goes in the first half of the day. So I've seen a lot of IMGs getting evening shifts, which some of the locals doctors may not want to do. So the evening shift may run depending on the hospital, which it can go either way from 2 to 10 or from 4 to 12, as I do that. Essentially, with the evening shift, a little bit of a disadvantage is that the consultant is not there all the time. So the consultant may be there for the first half of the shift, and then after 5 o'clock, you're sort of managing it with other people who are at the same level as you are, residents or registrars. So you don't really have that consultant sort of a guidance over there. Now with myself, look, there were some things I was good at, some things I really struggled with. I did struggle a little bit with IV cannulation, particularly the cannulation packs and everything was very different. So make sure you familiarize yourself. ED is not the best place to learn that sometimes, because if it's a busy ED, they expect you to do everything really quick. And if you're trying to take up somebody else's time or put a lot of time on one patient, they don't like it. And I sort of learned that in a hard way. The consultant came to my room and said, "Oh, like you go and do something else. I'll do this," because I took like 20 minutes to get my cannulation done. It's also difficult if you haven't done that regularly over a course of time. So that's something you might want to look at and maybe go in a little bit early before your shift, a couple of hours, and have a chat with a nurse who's a little bit friendly, and they might show you the tricks of the trade. So in terms of the patients that I saw a range of patients. Yesterday was more so a surgical sort of a day. So I saw a guy with a cut on the hand. That was my first patient. And it's an expectation over here that as an HMO, you'd be able to do suturing. So luckily, I've done a bit of suturing. So I had a quick brush up, had a quick look at a YouTube video just to brush up on some of the skills. But yeah, I did a simple interrupted suture on the hand. So that was good. Then the next patient I got was a kid who had periorbital edema. So essentially bee sting, anaphylaxis. How you going to deal with it? If it's vitally stable, you don't need any epinephrine. Just go with some systemic steroids for 3 days and some antihistamines, and that should do the trick. After that, I got a female with headache, essentially a chronic presenter in the ED. So one of the one of the nurses actually gave me a heads up. So I put her on a chlorpromazine, which is an antipsychotic slash, relaxing agent, which sort of helped her. I made sure that her vitals and everything was stable. She was having a chat at the end of the session, so that was great as well. Then I had another elderly person who had a wound, and essentially he had a knee replacement and the wound got infected, so I had to involve the surgical registrar. Now, one of the tricks is over here when you do a handover or a referral to another department from the ED, they're particularly cruel on you. They don't want to take any new patients. So they'll grill you with questions and you have to convince them that this is your patient. You need to take care of it. It's not my responsibility. So you need to learn skills for negotiation as well. And if you're a little bit soft, they won't take the patient. So make sure you know your patient really well and you're very good with your articulation and you're able to convince them, okay, this is your job, you got to do it. So I'll give you an example. So for this patient came in with an infected wound. He fell on the wound. He had a total knee replacement some time back. Was previously referred to surgery due to septic arthritis. Came in now. He was bleeding from the wound. I had a look at the wound, called the ortho registrar, told them this is such and such is the case, and given this, you guys have seen this patient before. The wound is quite significantly big. There's a big flap on the wound. Could you? It's something I won't be able to deal myself. I would like you to have a look at it and make sure if nothing else is wrong with him. So something along those lines, and he would start saying, "Have you done the X-ray?" Which I hadn't because it wasn't a very deep wound, or I didn't feel that there was a fracture involved. But then I got the X-rays done, gave it back to them, and they were happy to have a look. So that's one more example. Then I got another case where a lady with abdominal pain, lower abdominal pain, elderly lady. So query, it was a bowel obstruction, maybe secondary to having some sort of metastasis or bowel cancer, which is pretty common in Australia. So that was an interesting case for me because in Australia you can easily go and order CTs all the time, whereas where we come from, we sort of are a little bit hesitant to order CTs. We'll do an ultrasound or an X-ray first to rule out things. Here, just go for CT. So that's something I've learned now in the system. Initially, I didn't order it, but later on, I figured out that's the way it needs to roll over here. Another patient I saw was a lady came in with palpitations, but essentially anybody coming in with chest pain, ECG, chest X-ray is a must. You do that, you show it to the consultant, look at the vitals, and then worry about things from there. Essentially, her ECG was clear, chest X-ray clear, gave her a little bit of pain medications, and essentially figured out the palpitations were secondary to some sort of social anxiety that she had. So you need to take a bit of a history from the patient. The expectation from you as an HMO is that you're pretty quick at doing things. Your job is to differentiate an undifferentiated patient, which basically means that you figure out what's wrong with the patient, what needs to be done, why they've come over here. So the way the consultant explained me, you need to figure out why they've come over here, what are you going to do, what's your plan, and then make an appropriate referral. So that's what you need to do in the ED. Now, I am trying to learn quite a few things. I got stuck in terms of the medication names. Geez, I don't remember the names of the medication, the doses, so I'll get stuck all the time. So I'm trying to ask for help from the nurses, or I'm using the Australian AMH manual, which is Australian Medical Manual for Health or something along those lines, which is available online. So I have a look at that, type the name of the medication. And I also use quite a bit of ETG to figure out what is the appropriate medication that or drug that needs to be given in that condition. So yeah, so that's pretty much it from my end. Let me know in the comments what else would you like to know from me. I'll be happy to assist.